Thank you, sir. And thanks to ISOT for giving this opportunity to present this issues on related to the swab transplant program. Uh, and good morning all. Thank you, chairpersons. So, if you look at the current need and the patients in the waiting list, so current need we estimate for kidney transplant to be 2 lakh annually every year. This is the new patients. Liver is 50,000, heart is 50,000, and we currently have total of 90,000 patients in the waiting list, out of which 63,000 plus is in the kidney. And this is the number we did in 2023. 24 number we are verifying again and again because we have certain doubts about the figures from the hospitals. So we had deaths also which were reported by the hospitals on the waiting list. So 1,277 deaths in kidney transplants, which were reported by the hospitals during 1 year while on the waiting list. So 23 comparison, if we look at this of the top 10 countries which performed highest number of transplantation in the world. So India continues to be at number 3 after USA and China, and our cadaver transplant numbers still continues to be very low, which is indicated by the by the blue graph, and our living donor transplant number is highest in the world. So that is the trend which has been there, and it is still continuing. So last year we have reported 1128 donors, 1128 donors, out of which we could conduct 3236 deceased donor transplants. So currently we are in a situation of donor crisis because requirement is huge and our donor numbers are not matching, and they are very low as compared to other countries. And out of in the kidney transplantation, the total percentage of deceased donors transplant is 12.17%, and in the liver it is still little better, around 18%. So you can imagine that still we are so much dependent upon the living donor transplantation. As of now, more than 700 organ transplant centers are linked with NOTTO for registering their data, and out of which, if we look at the kidney transplant number, so it is 83 kidney transplant centers are in government and 566 centers are in private. So roughly you can say around 15% are in government and rest all are in private. 649 is the total kidney transplant centers which are linked with NOTTO. Similarly, you can see the breakup in liver, also very low numbers in government. So that is another big issue we have in the transplant program, that our infrastructure in government is poor for carrying out the transplantation. So we have this law that we all know. Our law allows living donation by anyone who is 18 years or more, and deceased donation any age. We have licensing authority which is appointed by the state, and we have a authorization committee which approves the living donor transplants. And our law also permits exchange between near relatives, that is the swab transplants, and we have a opt-in system where the person has to agree for transplant and give consent. So basically, as you all know, health is a state subject. But these two mandates were given to the central government in 2011 Amendment Act. So only these two mandates, that to establish a network and to maintain a national registry, and national registry of donors and recipients of human organs and tissues. And so basically the central government has been given these two mandates. So based on this mandate which was given to the central government, this three-tier structure was created, and there is a gazette notification which has notified this network, and the gazette notification says that the jurisdiction of this network is over entire country. So this gazette notification is there on the NOTTO website, and there is another order by the central government which says that all the functions of the network will be carried out by NOTTO. So that is to establish this network and to maintain the registry. So that is the responsibility which has been given to the NOTTO. So these are the main roles and functions of NOTTO which are there, which have been prescribed as per this gazette notification and the order of the ministry, that to draft policies, guidelines and SOPs, to carry out any research in collaboration with ICMR if it is required, or in collaboration with other institutes, then networking, to have a networking all over the country and maintain a registry, carry out awareness, all the organ allocations, basically coordination and allocation, trainings, organ pledging, maintain a data bank. So these were the main, these are the main functions which have been envisaged for the NOTTO. So we have this networking, which is basically three-tier structure at national, regional and state level, and these three types of organization, they network with the organ transplant centers, retrieval centers and tissue centers. So right now, as I told you, there are 966 centers which are as part of this network, and out of which 700 plus are organ transplant centers. Now this network has expanded all over the country, and currently we have 30 states where the SOTO is there, and only very few, Ladakh, Lakshadweep, Sikkim is in fact has also been recently approved, but the order is yet to be issued. And then Manipur, Nagaland, Andaman and Nicobar, only these few union territories or few states of the northeast are not part of this network. So currently 30 states are part of this network. So these functions I've already told you, and this law allows donor exchange. That is the paired donation, as we know. And so basically, as you all know, that what is a swap transplant or a paired exchange, when the two biologically incompatible donor-recipient pairs, they exchange organs so that each recipient receives a compatible organ from the other pair's donor, overcoming the incompatibility which has been there. So as per this section of the Transplant Act, the first donor who is compatible biologically as a donor for the second recipient, and the second donor who is compatible biologically as a donor for the first recipient, and both donor recipients in the aforesaid group of pairs, they enter into a single agreement to donate and receive such human organ or tissue or both, according to such biological compatibility in the group. The removal and transplantation of human organ or tissue as per the agreement shall not be done without the prior approval of the authorization committee. So this kind of a arrangement, it has to be through a common agreement, and it will be done with the prior approval of the authorization committee. Usually incompatibility which is encountered among donor and recipients is either a blood type incompatibility or a tissue type incompatibility or a sensitivity related issue that has been observed. But there could be other types of incompatibilities also. What are the issues and challenges in these swap donation and transplantation? So one issue is that whether we carry out these transplantation which are agreed through a single agreement between incompatible pairs, whether they should be done simultaneously or they can be done non-simultaneously also. Like we are not, because in our institutions we don't have, sometimes when the chain is more, or it is, because this, though the law mentions one donor recipient, but it can be extrapolated to the chain of donors and recipients also, as is in practice in some of the institution, and that is not illegal. That is very much allowed, because if there is a provision that can be extrapolated to extend to more such pairs. So simultaneous or non-simultaneous is one issue. Then should it be paired three-way or it could be multi-way? Then exchange between an Indian pair and a foreigner pair. So if we have foreigners who are coming here for transplant and there is an incompatible pair, so whether that can be allowed. Then single center or multi-center. As of now, it is mostly a single center swapping which is done. Then can it be same city or within multiple cities? Can be within same state or multiple states? Then there is a issue of approval from multiple authorization committees if it is in different states. Then should it be anonymous or non-anonymous? So that is another big issue, that whether the donor pairs and the donor and recipient pair, they should be knowing that who is donating that kidney to them and where this kidney is going. So right now it is a non-anonymous which is in practice in our country. Then use of matching software. We have, two software I think are in practice. One of them is, which is there from the Nobel laureate, which has been being used by certain centers. And then we have ISOT software also. Then there is always a need for transparency, but is there a lack of transparency in some of these donations? Then right now we don't have a registry, particularly only institution-based registries may be there, but we don't have a city-based registry or a state-based registry or a regional registry or a national registry for swab transplant. So to have a practice of swab transplant, such registry is needed. Then there are also concerns that if it is non-anonymous, there could be coercion or there could be financial dealings also. So that concern, are we taking care of those concerns? Then there are other issues of gender, issues. Gender issues, because the law allows exchange only between near relatives. So we have in our country, the wives and the sisters, they are donating more as compared to the other near relatives. So, and females are there. So whether we have certain gender issues also reflected in these exchanges, then could there be other influencing factors like age difference between the donor and recipient? Organ health. How is the organ health of the donor, particularly from both the sides? So if there is a difference between the health of the functionality of the organs between the two donors, so whether that exchange can be a balanced exchange. Then fitness of the donors, again between the donors which are being exchanged. Then acceptability, how to make it more acceptable or more transparent for the families which are involved. Families of the pairs of which are involved. And acceptability not only by the families but also by the transplant surgeons. So then should it be a same organ swap or it could be a different organ swap? That is, kidney being swapped for liver or liver being swapped for kidney. So that could be. So these are the various issues and challenges which I envisage in case of a swab donation or a paired exchange. So as you know, every swap or paired exchange has to be approved by a authorization committee. The authorization committee can be state or district or hospital level as permitted under our law. And authorization committee, as you know, is for approval of three types of living donors. So one is other than near relative, second is swap cases, third is any case where a foreigner is involved. So even if near relative, if donor or recipient is a foreigner, then also the approval is to be done by the authorization committee. And you all know that authorization committee is a 7-member body. It is headed by the hospital medical director or medical superintendent, or in case of a state or district level authorization committee is headed by the designated chief medical level officer, chief CMO level officer of the hospital, prominent hospital of the district or the state. So if we have a district hospital, then CMHO of that hospital will be heading, and there are examples of each type of authorization committee in our country. We, like in a state like UP, we have district level authorization committees. In Delhi, mostly authorization committees are hospital based. In some of the smaller states, we only have state level authorization committee. Even in Mumbai, I think it is a state level authorization committee, which is there to take care of these such cases. So there are 2 medical experts, 2 persons of standing or the eminence, and one of them should be a female out of these, and 2 government nominees, one of the director health services, one of the secretary health. So which authorization committee will approve these swab transplantation cases? So it is the authorization committee where the transplant is going to take place has to approve these cases. So like suppose it is a hospital based authorization committee of the IKDRC, then if the transplant is taking place in IKDRC, then the authorization committee of IKDRC will approve. But, and suppose there is no hospital level, then the district authorization committee of the Gujarat, that particular district will approve, or the state level authorization of Gujarat. So where the transplant is going to take place, that authorization committee will approve the particular case. So what are the various forms and which are there, which need to be looked into? We have various forms which are required for approval of these paired exchanges or the swab donor transplantation. So form number 1, 2. One is, it's for genetically related near relative donor, and form number 1 is required when the donor which is being exchanged, one of them is a genetically related donor. So because that authorization committee by this form will see that this particular donor which is being offered is a genetically related, so that form is to be there. Then form 2 is in case of a spousal near relative donor. Then we have form number 5. Form number 5 is for again a genetically related donor where the DNA matching is there. But I tell you very frankly that DNA matching is not compulsory. But many of the states are, has been practicing it as a compulsion. Because somewhere there is a confusion, but there is a clear rule number 18 in our transplant rules which says that whenever there is a doubt about the identity of the donor or the relationship between them, the donor and recipient, then only you can order this DNA matching for establishing the near relationship, particularly in case of a genetic. But if you require HLA match, definitely even this HLA match will not be in this case of a near, because the particular near relative is not donating. He is donating to the other pair recipient, who is not a near relative. So that HLA match with him will be required, but not with his own near relative. Then we have form number 6, which is again in case of a spousal donor, where we take extra precaution in to basically to look for other documentary evidence that particular person is a spouse. And particularly in a female, we look for marriage certificate, the age of the children, etc., and when the donation has been agreed upon. So those duration of marriage, etc., is looked into. Then we have form number, form number 11. Form number 11 is the form where you enter into a joint agreement. And this is the first form actually which is filled where all the pairs where they enter into a joint agreement, and then they basically that is processed by the particular hospital where the transplant is going to take place. Then we have form number 18. 18? Yeah, it is 18. 18 is a form for approval by the authorization committee, basically for decision of the authorization committee, and it is to be signed by the authorization committee. So that is not required by the patient, but it is required by the authorization committee. Form number 20 and 21. It's 20. It's very, the number is not visible. So, so it's a 20 is basically a verification certificate by the Tehsildar. So this is required in case of, in these swap cases, it will be required. Why it will be required? Because actually the donor is not a near relative. The donor is donating on behalf of his near relative, but to the person who is the recipient, he is not his near relative. So this is required when suppose the transplant is taking place in Delhi, the donor pair, this particular pair which is coming for exchange is coming from UP, then it is required from the local Tehsildar of the area where the donor resides. So this is required just to establish the legal and residential status of the donor, that yes, this particular donor is residing at this place. So that is just the verification, and it is only required in case of outside the state cases. Then we have form number 21, which is required in case of a foreigner, and where the relationship is established, is certified by the embassy of the country to which the donor or the recipient belongs. So these are the various forms. So just in nutshell, if we see the form number 1 and 2 as applicable, if the near relative is a genetically related donor or it is a spousal donor, then identification documents for each donor and recipient, we should have identification documents. So minimum 2 identification documents of the donor and recipient we recommend. Suppose it is a PAN card, it is an Aadhaar card, or it is so minimum 2 identification documents of each donor or recipient is recommended. Then relationship document. Relationship document, that because this person is donating on behalf of his near relative, so that relationship documents are also required. So and कि ये इनका father ही है, ये इनका बेटा ही है, तो जो exchange के लिए आ रहा है, तो उसके relationship proof. Then form number 5, as I told you, it is a genetically relationship, but it will be, it is not mandatory here because this person is not donating to his own genetically related, but in case you want to verify the relationship, then this form number can be one of the relationship document. So that is one. Second, the form number 5 is required for HLA match between the actual donor and actual recipient. So those two which are being, so that form number 5 is required for compatibility, tissue compatibility match also. So that is form number 5, the importance is like that. Form number 6 in case of spousal donor for extra precautions. Form number 11 is the joint agreement. Form number 20, verification by Tehsildar if the transplant is to happen outside the state of domicile. Then form number 21 in case of foreigner. Incompatibility or compatibility related documents, because since the case is being presented that this particular donor who is going to donate to this recipient is compatible. So authorization committee has medical experts within its composition. They can ask for actually show us the proof of compatibility to which he is going to donate. So actual donor, so that compatibility and incompatibility कि इनका अपने से incompatible है, but जिसको donate कर रहे हैं उससे compatible है. So those documents can also be asked by authorization committee. So these are the documents which I think will be required for approving a swab donor transplantation. So what are the restrictions on removal of human organs and tissues? This is also important to know that in our law, generally we say that the donor should be a near relative whenever we are permitting. And other than near relative, we can permit for the reason of affection and attachment between donor and recipient. Then there is always a confusion whether Indian pair can exchange with a foreigner pair. As of now, if you read this, which has been highlighted, the authorization committee shall not approve such removal or transplantation if the recipient is a foreign national and donor is an Indian national unless they are near relatives. So ये बड़ा clear है, this is an overriding clause कि कोई भी Indian किसी भी foreigner को नहीं दे सकता organ जब तक कि वो उसका near relative ना हो. तो चाहे आप उसको स्वैप करा के देना चाहे तब भी नहीं दे पाएगा. तो इसलिए ये overriding clause है. So swapping between an Indian pair and foreigner pair is not permitted under the law because this is an overriding clause कि जब तक वो नियर रिलेटिव नहीं होगा तब तक कोई भी इंडियन डोनर किसी भी फॉरेनर को नहीं दे सकता. तो स्वैपिंग भी नहीं हो सकती है कि आप सोचे कि वो स्वैप करके दे देगा, नहीं दे पाएगा. तो वो लीगली परमिटेड नहीं है. हमारी तरफ से एक एग्जीक्यूटिव लेटर सबको इशू किया गया है कि वंस द डॉक्यूमेंटेशन इज कंप्लीटेड द अप्रूवल ऑफ द केस शुड बी डन विद इन 7 days. So by the authorization committee, but we definitely get complaints of delays from the various patients also. But there is a letter from the Ministry of Health side, and again we have also defined detailed timelines as per the court order which is there on the NOTTO website कि हर stage के लिए भी हमने timelines define किए. But once the documentation has been completed, within 7 days, the authorization committee has to meet and give approval or rejection, whatever they want to. They have to decide within 7 days. And similarly, the appeal committee, which is there, they also have to decide once they have received their documentation complete, then they have also to decide within 7 days. So that is there from the NOTTO side already. We should also be aware of the offenses and penalties which are provided under law. Why should we be aware? Because sometimes there is a possibility of creating false document, or somebody is publishing advertisement inviting donors for exchange or like that. So this can happen even in case of exchange, and or somebody is making payment or for supply, or seeks a person willing to supply for payment, or negotiates any arrangement, or create false documents of relationship. So we should be aware that the penalties are very stringent. Minimum 5 years of jail, which can go up to 10 years, and fine minimum 20 lakh rupees, which can go up to 1 crore rupees. And both jail and fine, they are implemented, and it is not either of them, it is both. So these are the various, offenses which can happen in paired exchange also. Currently, the government is focusing on prevention of organ failure also, or preservation of organ health. Because as we know, as yesterday also I was saying that 30% of our population is now having some degree of fatty liver, and 10% is having some degree of chronic kidney disease. So 40% of our donors are becoming unfit. So we have to have fit donors also to have exchange or to promote living donor transplantation. So as many studies have pointed out that paired exchange has potential to improve numbers by more than 30%. So we want to promote paired exchange, but we want healthy donors also. And some of the, like controlling dietary fats, physical inactivity, smoking, obesity, high calories or processed foods to be avoided, unnecessary medication, controlling blood pressure, stress, alcohol, and blood pressure, managing your blood pressure and blood sugar. So these are very important, which now government is focusing on. So we are to move towards self-sufficiency in organ transplantation. We have to work from the demand side also, improve the donation. And today I'm happy to inform there is a mega pledge registration drive is going on, by the Indian Army, and even the army men who are posted in Goa, they are also being involved. And more than 10,000 people have pledged since 6 a.m. in the morning till now. And this registration drive is going on as of now on this auspicious day of the, Ram Navami. So we want to have at least one government multi-organ transplant center in every state, organ retrieval center in every medical college or a trauma center, establish the systems for donation after circulatory death, improve the swab donation numbers, only few centers are active, and Dr. Vivek Kutte is perhaps the most active one who is pushing this program, and he has published many papers. Improve standards and outcome, and training and capacity building. So these are the various actions, and we are looking forward to have one single platform, one nation, one swab transplant program also, one portal, one registry, and computerized and matching allocation. That matching which is done for paired exchange also to be computerized. So thank you so much. If you have any questions, I'm there to answer you. Thank you.